Hi guys, it's me, Professor D. Welcome back to my YouTube channel. On this video, I'm going to be going over pulmonary embolism. Now, before we get started, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it. So go ahead and press that like button. Give it a thumbs up now so you don't forget. Subscribe to my channel if you haven't done so already. And don't forget, I'm now offering next generation NCLEX reviews, private tutoring sessions, and consultation sessions. You can reserve your spot by going to my website right now, nexusnursinginstitute.com. Well, not now because you got to watch this video, but afterwards, you go reserve your spot, nexusnursinginstitute.com. And while you're there, check out the audio lessons that I have available. These audio lessons, guys, they're made specifically for the nursing students who are currently in the program that are struggling. Like, you have to get a really, really high grade on your next exam or you're out of there, right? So that's who I made these audio lessons for. I go over the most important things that you need to know for that upcoming exam to pass. Now, obviously, I don't teach at your school. However, there are certain concepts in every disease and disorder that as a nurse, you absolutely need to know, right? The chances are high that you may see that concept probably on an exit exam or even NCLEX. So I touch on those. So if you're in the nursing program and you're struggling, I encourage you, go over there, Nexus Nursing Institute, and check out the audio lessons that I have available. Now, pulmonary edema. Let's take a look at the etiology and patho. And even before I get into that, just look at the title, pulmonary. Did I say pulmonary edema? Did I just say that? I meant embolism. If I did, I'm sorry. Pulmonary embolism. So pulmonary, we're talking about the lungs. Embolism, that is, it can be it's a foreign body that moves somewhere. So for example, if the patient has a clot, right? Once that clot starts moving, it's now an embolism. If it goes to the lungs, guess what? It's a pulmonary embolism. So let's talk about pulmonary embolism. This is a blockage of one or more of the pulmonary arteries by a thrombus, that's a clot, by fat, or by air, okay? By thrombus, fat, or air embolus. So it's moving. Or tumor tissue. So emboli, these are mobile clots that generally do not stop moving until they lodge at a narrowed part of the circulatory system. A pulmonary embolus consists of material that gain access to venous system and then to the pulmonary circulation. Let me stop right there. As students, you will sit there and read those two sentences and just keep going and act like you understood what it just said. No, stop. When you're reading something, you need to make sure you understand what it's saying. So the emboli, this moving clot, usually doesn't stop until it lodges itself somewhere, right? It lodges itself into a narrowed part of the circulatory system. And guess what? Once it lodges itself somewhere, how's blood going to get through? So already we know there's going to be a problem with circulation. Already we know there's a problem with blood flow. Already we know there's a problem with oxygen getting to where it needs to go, because remember, oxygen is carried in the hemoglobin, which is carried in the red blood cell, which is part of what? The blood. So reading those two sentences right there just told us a lot of things, but you have to take the time, guys, to stop and make sure you understand what you are reading. It continues to say a pulmonary embolus consists of material that gains access to the venous system and then to the pulmonary circulation. Let's stop right there. So very often what happens is a patient will have a clot, and usually it'll be in a lower extremity, right? It'll be the left lower extremity, right lower extremity. And then that clot dislodges and then it goes to the lungs. And now we have a bigger set of issues. That's why it's so important. You guys got to know, and I'm going to go over this in a little bit, but you guys got to know the patients who are at risk for throwing clots. Now, let's keep going. Second paragraph, I'm down here. See what it says? It says most pulmonary emboli arise from DVT, deep vein thrombosis in the deep veins of the legs. What happens to blood when it's not moving, when it pools? Guess what? It clots. That's why it's so important to get patients to move around, especially those patients who just had surgery. They've been on that surgical table for hours. They haven't been moving. Chances are what? That blood can start to clot, right? We don't want them to develop a DVT. Matter of fact, when you get a test question, the minute they say that this patient just had surgery, this patient had invasive surgery, I don't care what type of surgery it was. It could have been a mastectomy, it could have been anything. They had invasive procedure. One of the three things you're going to be most concerned about, you're going to be actually looking for in the answer of your nursing intervention is going to be towards what? DVT prevention. Why? Any patient who had surgery, we're always going to be concerned about them developing a DVT. And God forbid, that clot dislodges, it moves, it goes to the lungs, developing a pulmonary embolism, right? What else are we going to be concerned after the patient had surgery? We're going to be concerned about hemorrhage. So we're going to be watching out for those signs and symptoms of hemorrhage. And of course, we're going to be concerned about infection because it was an invasive procedure. But automatically, those three things need to be going on in the back of your minds. Let's keep going. I'm right up here, guys, okay? Let me make this a little bit bigger for you. All right, so it says, in addition to dislodged thrombi, less common causes of pulmonary embolism include, notice, guys, I have this highlighted, and I wrote NCLEX next to it. What does that tell you? All right, okay. So you need to know other causes of pulmonary embolism. Here's the list. Fat emboli from fractured long bones. NCLEX is famous for asking about this, and so are, like, HESI and ATI, especially those exit exams. The minute you see in the situation of the patient, you see that the patient had a long bone fracture, automatically in the back of your mind, one of the things you need to be thinking about is fat embolism. Because where do you think the fat globuli are? Right there in the long bones. Okay, so if the patient has a long bone fracture, such as, they have a femur fracture, they have a rib fracture, what do you think they're going to be at risk for? Fat emboli, because all those fat goblets, did I say that right? Globlets or I think it's goblets, not globlets. Somebody tell me in the comment section. I don't remember. But anyway, those those fat, guess what? Once that long bone breaks, now it's free. It's circulating in the bloodstream. Okay. So risk factors for pulmonary embolism: fat emboli, especially fractured long bones; air emboli, this is also important, from improperly administered IV therapy; bacterial vegetation on heart valves. Let's talk about that. Whenever you have a foreign body placed in your body, so a patient has surgery and they get something placed into their heart, guess what? Bacteria loves to clump up in that area. They love to go wherever there's a foreign body. So that bacterial vegetation where they clump up, it might break off, and guess what? Go directly to the lungs. That's what they mean when they say bacterial vegetation on heart valves. Amniotic fluid and tumors. This list that you see I highlighted and I put NCLEX next to it, make sure you know it. If you're studying for an exit exam, you're studying for NCLEX, make sure you know other causes of pulmonary embolism. Let's keep going. Risk factors. Did not tell you need to know them? Yes, you do. I didn't highlight it, but look what I wrote on the bottom. Usually they're seen as select all that apply on NCLEX, ATI, and HESI. You have to know these risk factors. What are they? Immobility, not moving. Remember, when blood doesn't move, it clots, right? Immobility, reduced mobility, surgery within the last 3 months, especially pelvic and lower extremity surgery, patient having a history of DVT already, malignancy, obesity, oral contraceptives, that is a famous one for NCLEX, hormone therapy, cigarette smoking, that's another one, prolonged air travel, heart failure, pregnancy, and clotting disorders. Don't shoot the messenger. You guys absolutely need to know this stuff. Clinical manifestations. What's this patient going to look like? They're going to have a shortness of breath. They're going to have dyspnea. Look what it says right here. I'm right here. Where am I? Here we are. Dyspnea, most common cause presenting symptom occurring in 85% of patients with PE. Okay. Dyspnea, hypoxemia, tachypnea. We're going to see the respiratory rate go up. Why? The lungs are trying to compensate. Cough, chest pain, hemoptysis, crackles, wheezing, fever, accentuation of pulmonic heart sound, tachycardia. Why? The heart's trying to compensate as well. Think about it. We have something that has lodged itself in a vessel, blood's not circulating, oxygen's not getting where it needs to go. The lung's going to try to help out by increasing its rate, and the heart's going to try to help out. Remember, the heart is responsible for delivering oxygenated blood to the tissues. So the heart's going to try to help out also by increasing its rate. That's why you see the tachypnea. That's why you see the tachycardia. All right. Syncope. Massive emboli may produce a sudden change in mental status. Let's stop right there. I tell you guys all the time, whenever you are reading like a case study or a patient situation, the patient was awake, alert, oriented. Now, all of a sudden or suddenly, they're confused, they're irritated, they're agitated, they're lethargic, there is a change in the level of consciousness, there is a decrease in cognition. Stop. Something is seriously wrong. We don't know what it is yet, but we know that patient's a priority, right? Change in mental status, hypotension, and feeling of impending doom. Sometimes the patient can't explain to you what's wrong. They just say to you, I feel like I'm going to die. Something's very wrong. They're agitated. They're anxious. A lot of times in test questions, they'll say anxious or they have anxiety. That's that feeling of doom. Complications? Pulmonary infarction, that's death of the lung tissue. Think about it. Oxygen is not going to the tissue where it needs to go, right? Because that embolus has lodged itself. Death of the lung tissue. And 2, pulmonary hypertension. And this results from the hypoxemia. We talked about the decreased oxygen, hypoxemia from involvement of more than 50% of area of the normal pulmonary bed. Now, before I move on to the next page, I want you guys to take a look at this on the bottom. Look at this table. Causes of pulmonary edema. I want you to pay attention whenever you're studying, you're reading, and you notice that the author has already given you information in one form. It's been in a text. And they take their time to give you that same information in another format, such as a table or a diagram or a chart or an illustration. Why are they doing this? They're doing this because it's important. Most likely you're going to see it on a test. That's why they're presenting that same piece of information in another format. We saw this already. Now we're seeing this again in the table. You guys better know this. Causes for pulmonary edema, heart failure. I'm not going to go over all of them, but you guys can pause to read, make sure you know it. I'm just going to go over the ones that tend to show up the most on exams. Heart failure. Altered or decreased, capillary permeability in the lungs, such as, patients having pneumonia. Unknown causes can be opioid overdose or high altitude. Remember, we talked about the air travel. Okay, make sure you guys know this table. Diagnostic studies. There are several, so they can do the D-dimer. The thing about the D-dimer, it's not really specific and not very sensitive. Excuse me, I have to have my coffee. So patients with suspected pulmonary embolism, and if they have elevated D-dimer, but their venous ultrasound is normal, they most likely will do a CT or a lung scan. So a D-dimer, that is one of the diagnostic tests, but that's not the definitive diagnostic test because, again, it's not specific, it's not sensitive. But, if they suspect that patient is having a pulmonary embolism, they'll do the D-dimer. That D-dimer is also elevated, then they may start doing more specific testing. Again, spiral CT or a lung scan. Let's talk about the spiral CT. This is most frequently used to diagnose pulmonary edema. Why do I keep saying edema? I'm so sorry, guys. Embolism, pulmonary embolism, throughout this whole video. If you hear me say pulmonary edema, just know I mean pulmonary embolism. I'm sorry about that. Anyway, for the spiral CT scan, that's most frequently used to diagnose the pulmonary embolism, and an IV injection of contrast media is used. So think about it. if we know that with the spiral CT scan, this is the test that they use most frequently to diagnose pulmonary embolism, we know that they're going to use contrast media. We got to make sure the patient is not allergic to contrast media. We got to make sure they're not allergic to that dye. We got to make sure they're not allergic to what? Shellfish. Okay, keep that in mind. Anyway, if a patient cannot have contrast media, such as allergies to shellfish, a VQ scan is done. Make sure you know that. Pulmonary angiography is the most sensitive and specific test for PE. You need to know that as well. Pulmonary angiography. Interprofessional care. I put a star next to this one because remember, we always rather prevent than treat. So prevention of pulmonary embolism begins with prevention of a DVT, because usually what happens is the patient has that deep vein thrombosis, right? It breaks off and it lodges itself in the lungs. So we want to prevent the patient from having a DVT. So DVT prophylaxis includes, you need to know this, the use of sequential compression devices, early ambulation, and anticoagulant medications. Specifically, usually the patient will be placed on Coumadin, but there's other medications that they may give if the patient cannot get that. All right. To reduce mortality risk, treatment is begun as soon as pulmonary embolism is suspected. Notice it says suspected and not confirmed. Treatment begins as soon as PE is suspected. You expect the patient to be placed on oxygen. You're going to teach them to turn, cough, deep breathe. You're going to teach them to use their incentive spirometer correctly. You're going to teach them about the medications that they're going to be on. Let's take a look at drug therapy. It says immediate, all right, right away. Immediate anticoagulation is required for patients with pulmonary embolism. Sub-Q administration of heparin. Let's keep going. Excuse me. Sub-Q administration of heparin has been found to be safer and more effective than the use of unfractionated heparin. So the low molecular weight heparin, they find that to be more effective. It's a recommended treatment for patients with acute PE, and they're going to get it once a day. Coumadin, an anticoagulant, should also be initiated at the time of diagnosis. Coumadin is administered for at least 3 months and then reevaluated. Remember, guys, and I talked to you about this in another video about the bridge therapy for the heparin and Coumadin. Alternatives to Coumadin include, and they give you the list of these medications. I'm not even going to try to pronounce them, but you see it. So just go ahead, pause to read. Although not common, some healthcare professionals use direct thrombin inhibitors and fibrinolytic agents. Worst case scenario, patient will have to have surgery. Hemodynamically unstable patients with massive pulmonary embolism in whom thrombolytic therapies contraindicated may be candidates for immediate pulmonary embolectomy. Worst case scenario, that's not our first go-to when it comes to pulmonary embolism. Look at the nursing management for pulmonary embolism. You're going to keep the patient on bed rest in a semi-Fowler's position to facilitate breathing. You're going to put that patient on oxygen. You're going to maintain an IV line for medication. You're going to make sure you're monitoring the patient's lab results. You're going to be looking at the INR for Coumadin, the PTT for heparin. If you guys have a hard time remembering the difference, PTT, those two T's, if you take a look at this right here, guys, those two T's kind of can look like an H. That H stands for heparin. So PTT's for heparin, where the PTINR is for the Coumadin, okay? Interventions related to immobility and fall precautions. Once the patient's out of bed, you're going to make sure that you're making sure that the patient's ambulating safely. Patient teaching regarding long-term anticoagulant therapy is critical. Anticoagulant therapy continues to last for 3 months. This is about the second or third time I'm seeing this, right? They told us this already, but it's so important you're seeing this again. You have to know that. INR levels are drawn at intervals and Coumadin dosage is adjusted. I want you guys to take a look at this. Look at this table, interprofessional care. So pause to read because I'm not going to go over all of these. So pause to read it, guys. But for diagnostic testing, you expect to do that, the spiral, CT scan, VQ, the VQ, the D dimer, you're going to be looking at the trope levels, BNP, pulmonary angiography for management. Patient's going to be on oxygen. You're going to be looking at the PTT, INR, drug therapy. Fibrinolytic agents, unfractionated heparin, low molecular weight heparin, Coumadin, opioids for pain relief. One more thing I want to go over with you guys. I want to say it's on page, let's see, page 818. Let's check that out. By the way, look at this. When you're reading, right? Look at my finger so you can follow along. When you're reading, and then in parentheses, it tells you to see chapter blah, 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 page blah, blah, blah. Why do you as students overlook that and you just keep on reading like you didn't just see that? That same information they're telling you to go refer to, you know how many test questions you're missing out on because you wanted to be lazy and not look at that information? That information they're telling you to refer to usually is, detailed information on what you already saw, but guess what? They're repeating themselves. What did I tell you about information that repeats itself when you're studying? It's important to know. Most likely you're going to see it on an exam. So don't do that, guys. When they tell you to refer to something, go look at it. You never know. Looking at it might give you a couple of extra test questions. All right, let's go to page 818. Okay, so look at what it says right here. Early and aggressive mobilization based on the patient's condition. We're going to want to get them moving around as soon as possible because one of the things that causes clots in the first place is not moving. So we want the patient to move around. Patients on bed rest should, if for whatever reason, if we cannot get them moving around, they're on bed rest, we still want them to do exercises in the bed. We don't want them just lying there. Patients on bed rest should change positions at least every 2 hours, unless contraindicated. You're going to teach the patients to flex and extend their feet, knees, and hips every 2 to 4 hours while awake. Patients who can get out of bed need to get out of bed, okay? Patients who can get out of bed need to be in a chair for meals, and they need to walk 4 to 6 times per day if they're able to. We need that blood circulating. We need the patient to be moving around. We talked about this compression stockings. You're going to encourage the patient to wear compression stockings. They are part of the VTE prevention in hospitalized patients. These stockings decrease VTE risk in surgical patients. Now, I encourage you to pause to read. If you don't know how the stocking should be applied, make sure you pause to read, because I've seen on HESI exams where you have to put it in order how the stockings are applied and the proper versus improper use of those stockings. So make sure you pause to read if you don't know that. Intermittent pneumatic compression devices, IPCs. These are inflatable sleeves or boosts to compress the calf and thigh and or foot and ankle to improve venous return. That's something else that is used. Again, pause to read. Let me make this a little bit larger for you. If you don't know how they are used, make sure you read these. I'm not going to go through all of that with you, but you guys do need to know this. This has been asked on HESI as well. Drug therapy, anticoagulants. We talked about the heparin. We talked about the Coumadin. Make sure you guys go and read about those in detail. You're going to take a careful history before you start your patient on Coumadin. Do not give antiplatelets or NSAIDs with warfarin, that's your Coumadin, since these drugs increase bleeding risk. You see that statement? You will, if you're taking fundamentals of nursing, you're going to see that on a test somewhere, right? You go to cardio, you're going to see that on a test somewhere, and you may see it on your exit exam as well. Make sure you know that, very important. Oh, pharmacology as well. A diet that frequently varies in vitamin K intake, green leafy veggies, can make it hard to achieve and maintain a target INR level. Why? Because vitamin K is the antidote for Coumadin. So if this patient is taking Coumadin, what we used to tell patients to eat a diet low in vitamin K, but research has shown that's not as effective as teaching the patient to keep their diet stable. So whatever, if they're used to eating green leafy veggies, to keep that consistency, because remember, we're going to be checking that PTINR, but we're going to tell them to be consistent in their diet of vitamin K, be consistent in their diet of green leafy veggies. Do not all of a sudden start eating a whole bunch of green leafy veggies if they did not before, and don't stop all of a sudden eating green leafy veggies or foods high in vitamin K if they didn't before. Okay, so the purpose is we want to have a steady level. We're going to be checking often. So that's also is important for you guys to know. Vitamin K is the antidote for Coumadin, just like protamine sulfate is the antidote for heparin. Make sure you guys know that. Anyway, guys, this is your pulmonary embolism in a nutshell. Please, everything I've gone over, make sure you go back and review the details. I'm giving you the meat and potatoes, but make sure you guys go back on your own and go over those details. But that's the most important thing that you guys need to know about pulmonary embolism. Please, in the comment section, let me know what you thought about this video. Let me know what you'd like to see me cover next or in the future or more extensively. And let me know what format you want me to teach it in. Do you want it like this in a lecture format? Do you want me to teach the information in a Kahoot format? Or do you want it in a question and answer format, such as the videos that I release every Sunday, 1 p.m. Eastern Standard Time? Almost daily, you can find me covering a variety of nursing topics on my other social media platforms, such as TikTok, Instagram, and Facebook. I'm now offering one-on-one tutoring sessions, consultation sessions, and I'm doing NCLEX reviews, guys. So go ahead, reserve your spot right now by going to my website, nexusnursinginstitute.com. And while you're there, be sure to check out the audio lessons I have available. This is made specifically for my nursing students who are struggling in the program right now, to kind of give you a leg up on your studies. Guys, thank you so much for watching this video, and you guys catch me on the next video.